Okay. All right. So as I said before, thank you guys all for coming. My name is Rachel. I'm one of the pharmacists here. And this is going to be, I wasn't sure who was going to attend and kind of what population we have here. So we'll start out with a little brief overview of just some kind of topic in heart failure pharmacotherapy. We'll go through a brief review of, our guideline-directed therapies. We'll talk a little bit about kind of how we're doing as a country. There's some new data out from a random sampling of some centers here in the U.S., and we'll see how we're doing from an ambulatory care perspective. Maybe some tips and tricks on how to triage some issues you guys may run into in your clinic setting. And then at the very end, we can wrap up. I put in a little tiny blurb about the ARB recall, because I figured that probably affects a large population of you guys. I know we've had that kind of as an issue here. So that'll kind of be essentially what the next 20-30 minutes will look like. If you guys have questions, do you guys usually ask as they come up, or do you wait till the end? Is there any formal way this is done? We're not sure. Well, you can ask as they come up when we have the slide up and things like that. It'll be very informal from that standpoint. All right. And with that, we'll go ahead and get started. So generally when we're talking about the heart failure population, you guys all know we're talking really about a tale of two different populations of patients. You see here we have both the preserved ejection fraction patients. So both the ACC, AHA, and the European Society of Cardiology would define that as an ejection fraction greater than 50%, where we don't have a whole lot of treatments that we have established for this patient population. There's some controversial data that came out about 2 years ago that aldosterone antagonists or mineralocorticoid receptor antagonists, such as spironolactone, may carry some benefit in a small subset of patient populations. But as far as data that show morbidity and mortality benefit, there's really not a whole lot in that group. So the big one we usually think of would be the reduced ejection fraction patients, or the EFs less than or equal to 40%. So that's primarily where this topic is going to focus on, a lot of these guideline-directed therapies that we have established, and kind of how to triage and transition those in the clinic setting. So again, as I mentioned before, it's a little bit lopsided here in terms of what we have from a treatment standpoint. I apologize for that. However, as you can see, there's a slight difference in reduced versus preserved EF. So we're primarily going to talk about reduced ejection fraction in this population of patients. I've only included, for a majority of this topic, guideline-directed therapy that has shown morbidity and mortality benefit. I will note here that there is some data for digoxin and ivabradine in reducing hospitalizations in patients, but for time's sake, I really haven't delved too far into that. So if you have questions regarding those agents and using those agents, we can just discuss those at the end. Okay, so just recently, actually about 2017, the American College of Cardiology got together and they created an expert consensus decision pathway, which was published in JACC and is accessible online to anyone who's interested in looking at it. It's a really nice, pretty succinct article that goes through, they picked out the 10 pivotal issues in heart failure with reduced ejection fraction, and go through each of these in, I would say, good detail in terms of what they have found success with and what the literature kind of has shown, and it kind of makes it a nice, distinct document. So as you can see here, the 10 pivotal issues, the top 2 of those are going to be medication related. So how really to start therapies, when to add them, when to switch, what really should we be doing, and in what order should we be doing them? And then how do we also, once we get these medications on board, how are we going to achieve these optimal doses and make sure that our patients are getting optimal therapy? What kinds of markers should we be looking at? What things can we do and assess in our clinic setting? So it's clear here that this is a high priority issue, and it's a disease state that's heavily reliant on pharmacotherapy, at least in the early stages. And so hopefully this will be helpful. So we'll start out with a very basic review just of the chronic heart failure treatment. So I'm sure every one of you, or a majority of you guys, have seen at some point in time this depiction here that nicely displays kind of the decision tree of when to start certain therapies and when to consider adding or adjusting those therapies from where we are now. And so this is a nice picture that came out of that consensus guideline, like I said, but it's been spattered about everywhere from all of the heart failure guidelines since at least the 2013 edition, I'm sure before that. There is some question here, so it provides ACEs and ARBs and beta blockers kind of on the same, I guess, level here at the top. So there was always a question of which one do you start first? How do we go about initiating them? The CBIS-2 trial was one that actually looked at this a few years ago, and they found that there's really no difference in terms of mortality or morbidity data if you were to start a beta blocker first and then add an ARB or an ACE or vice versa. And also clinically, when you're evaluating the patient in clinic, if they are a stable patient who is warm and maybe a little bit wet, or even if they're warm and not wet, in which case you're lucky, you could consider adding both of these agents in one setting and then triaging from there which one to titrate. So again, I just wanted to flash this up here for you guys all just for a reference to have as a slide. I'm sure everyone is pretty familiar with it. And this next slide here is very busy in terms of there's a lot of information on here. This is primarily and probably more for you guys if you are given the slides after this presentation to use just as a reference. It's just a dosing guide, really talks about all of the guideline-directed therapies, all of the trial data, where it came from, and what those starting doses are going to be, and then again, a nice reminder of what those target doses are going to be. I had the little asterisks up there with the carvedilol. Again, this is because the target dose is generally going to be 25 milligrams twice daily. However, in patients with a body weight of greater than 85 or greater than or equal to 85 kilos, they can actually go up to a dose of 50 milligrams twice per day, and that would be their target dose from that standpoint. So that's what that asterisk is for. And this includes all of the trial data for where this comes from. Again, primarily more for a reference for you guys, and it's probably things that you already know, but it's nice to have. It can also be used as a dosing equivalent type chart to help if you're trying to transition from one agent to another, as we've mentioned with some of these recalls and some of the other issues that are occurring. It could be helpful for a resource from that standpoint. This is another diagram or a picture that I pulled again from that expert consensus decision pathway. Clearly, I really like it. I think it's a nice, distinct resource, especially they have very good diagrams as well. It's all good and well to get these medications started. However, the hard part is then once we've gotten them all on board, when do we monitor? When do we adjust them? How do we do that? And how can we efficiently do that in a clinic where I'm trying to see 20 patients in a day or probably even more? I can tell you it takes a village. And so we are very lucky here. And I know one of the questions was someone is developing a heart failure clinic, and I think that is fantastic and wonderful. It will take a village. Here in our clinic, we are very lucky. We have 3 primary physicians that are rotating through the clinic. We have an advanced practice provider that's seeing patients independently as well. I myself, one of the pharmacists, there's actually 2 pharmacists here in clinic. We always have one of us there at all times. We have a dietitian, and we have 2 to 3 nursing or nurses that come in, and they will also see our patients as well as do follow-up phone calls and evaluate labs and things like that. So I think from the standpoint of building a clinic and following these things, and if you have a clinic or if you're using it in your primary practice, the more help you can get, the better. We can maybe try to come up with some tips and tricks and some strategies if you have less help and how to kind of make some of the stuff more succinct possibly. But if you're building a clinic, those are really key players and hopefully will be very helpful in allowing some of these titrations to occur. So I want to draw your attention here to the middle part of the slide. Can you guys see my cursor? I don't think so. Yeah, you can. The middle part of the slide here is where it really goes into detail about how should I be titrating these medications and how quickly should I expect to be able to get these patients to their goal dose or, whatever they might tolerate, because we know that ideally goal doses are great and they are a good outcome to strive for. However, we may not always be able to reach that because of patient-specific factors. So generally in our clinic, what we are following is probably about 2-week dosing titration strategy, generally because we don't see patients more frequently than that, and we oftentimes will take some time to get labs back and to be able to evaluate and assess the labs and to be able to give them a call back. We also like to speak to the patient and ask them about their blood pressures, about their heart rates, about their symptoms and things at home. So generally we're on about an every 2-week titration schedule. If somebody does have really high blood pressure, lots of room to go up, we would consider maybe doing a little bit more of a shorter titration, so doing it on a weekly basis. But things to always evaluate, again, I think down here at the bottom part of this chart, over here, it's going to have a good recommendation of exactly what those labs that we should be looking for are going to be. So we in our clinic are using BNP, or brain natriuretic peptide. I also like the NT Pro BNP. Whatever you have at your disposal is a good option to be trending in your patients as an outpatient, as well as a BMP, M as in magic. From that standpoint, you want to make sure you're looking at renal function and potassium. A lot of these agents can alter some of those in the acute setting, and especially upon initiation. So that can be definitely something that we are always getting with every dose titration. Okay, and as I was alluding to, so a lot of these therapies, especially ones that are going to be working on the renin-angiotensin system, are going to affect your serum creatinine upon initiation. That should be expected. Usually a slight increase, I would say anything less than or equal to 30% of what their baseline was should not be something that's overtly alarming in and of itself. A lot of these patients, or some of these patients, may have CKD at baseline, so that number I can't exactly tell you what it would be and be very patient specific, but less than or equal to 30% is very much to be expected. And it's not necessarily a reason to pull off the medications. It could be a indicator for more frequent monitoring or more slow titrations of these medications, but not necessarily something to shy or scare you away from using them at all or in general. Same thing for aldosterone antagonists. So I always recommend, and we are always monitoring BMPs within at least 1 week of initiation, just to see what's happening after the RAILS trial. I'm sure you all remember or may have heard of this. There was some anecdotal data of increased rates of hyperkalemia, because I think we found out that aldosterone antagonists improve morbidity and mortality, and let's just put them on everybody. And that would be the ideal setting, but we all know that we have patients we struggle with from a compliance standpoint. We have patients who don't come back to clinic, who don't get their labs drawn, who, they may live far away, they may have, reasons for these things. But when they do that, and we put them on an agent that we know has some side effects that can potentially be, put them at increased risk for arrhythmias and things of that nature, it can be a little bit alarming. And really, should this be a therapy that's given to everybody? I think it's a difficult decision to make, and I honestly do say consider reserving for compliant patients, just because, especially if their potassium is borderline prior to initiation, I would say, I don't know, over 4.2, 4.3, and then you're going to start it, and you don't think they're going to follow up, they're not going to be someone who comes back to clinic, it would be something that would make me a little bit nervous, because again, the risk of arrhythmia is there. Also taking into account what their history is from an arrhythmia standpoint too. So how are we doing as a whole? Like I said, there was some data that just came out, and we'll dig into kind of what's been going on from that standpoint. So the CHAMP Heart Failure Registry was data that was just presented in JACC at the end of 2018. It included 3,500 outpatients or ambulatory patients with reduced ejection fraction heart failure. They were from 150 primary care clinics as well as cardiology clinics. So this was a mixed bag of patients who were being seen by different and various providers. The purpose of this study was to essentially characterize patterns and factors associated with use of these medications, and to kind of target and see which patients are receiving first the medication at baseline, but then also receiving evidence-based doses of these medications. So it's just giving us kind of some real-world data about what's going on. We know that we have all these this previous literature, but really, how are we doing now? Patients were included if they had an echo within the previous year that showed a reduced ejection fraction, and they had to be receiving at least one oral heart failure medication at enrollment, which they excluded, or they did not count furosemide or any other loop diuretic as an oral heart failure medication. It had to be one of the guideline-directed therapies that we'll review in just a bit. And they excluded your usual patients, so those who had a life expectancy of less than a year, or were enrolled in hospice, or who had a previous heart transplant, LVAD, or were receiving hemodialysis. And this is essentially what they found. So this is a diagram here that shows the pink or red, however it's showing up on your screen, on the left side is the percent of patients who were eligible for some of these therapies. So they took into consideration, they did an extensive chart evaluation. So this was, again, not a prospective trial. It was just all data that they had gone back and chart reviewed. And so patients who had an exclusion met exclusion criteria for certain drugs were not counted in this group. But if they were considered eligible and they were receiving therapy, that's what's shown there on the left side, or on the pink or red bar. So 73% of patients were receiving some type of ACE/ARB or angiotensin receptor neprilysin inhibitor. 63% were on some type of beta blocker medication, and then again, only 33% of that mineralocorticoid receptor antagonist or aldosterone antagonist. I often refer to them kind of in the same picture there. So we got a little bit, and then the blue line is those who are not treated. So again, as the red line decreases, that blue line increases on the right side, and it just gives us a little bit of an idea of what these patients were on. So only 22%, so 1 out of 4, I think there's like 12 people in here, so 3 out of the 12 of us, if we were enrolled in this study, would have been receiving a dose of all 3 guideline-directed therapeutic classes. So this doesn't have anything to do with the doses. This just says, were they on an ACE inhibitor, were they on a beta blocker, and a mineralocorticoid receptor antagonist? So again, only 22%, a little less than 1 out of 4 patients. And then interestingly enough, only 13.1% of those patients, or patients that were eligible, were receiving angiotensin receptor neprilysin inhibitor therapy. Okay, and then last but not least, only a 1.1% of those who were eligible were receiving a target dose of all 3 guideline-directed therapies. Now, I will be the first one to admit that this is a difficult task to attain in any patient. However, 1.1% is a little bit of an alarming number just to take a look at and to kind of swallow. So since we're not getting to target doses, what doses were we really getting to? This is some data that was adapted from, again, that same article in that CHAMP heart failure registry. And it shows that everyone that's in the pink here is going to be somebody who is receiving one of these medications, but at a dose of less than 50% of what was recommended. So if your target metoprolol dose is 200 milligrams, they were receiving 100, less than 100, so not even including 100. And so as you can see, that's a majority of the patients in both of these 2 groups, followed subsequently by those that were between 50 and 100%, and then a very, very small portion, so 17% in the ACE, ARB, and ARNI group were receiving the target dose. 27.5% were receiving the target dose in the beta blocker group. So what this tells us is we still have some room to go. I don't know why those are coming in late. I apologize. And then again, this is the last one. For the mineralocorticoid receptor antagonist, if you remember back to the 2 slides previous, it had a lower percentage of patients who were on them. However, the patients that were on them, a majority of those patients, so 3 out of 4 of them, were receiving the guideline-directed gold dose. So this one, I think it was roughly 1,200 patients out of the total registry data were receiving mineralocorticoid receptor antagonists. It's about a third. But if they're on it, they're getting to the gold dose, which is probably a little bit easier to attain since it's only 25. But that is some positive information for us to take from here. Now, interestingly, this isn't the first time that we've evaluated this data and really looked at, how are we doing in the ambulatory setting, and are we doing, the best job of getting all of these patients on guideline-directed therapy. The Improve It Heart Failure group or trial was done in 2010, and it was 167 outpatient cardiology practices. So again, a little bit different than the population we looked at with the CHAMP registry. That was kind of all comers, similar in size from a study perspective. What they looked at is they looked at baseline use of the guideline-directed therapies, and then they implemented a 12 or 24-month improvement program that included education, patient data collection tools, performance feedback, and essentially a clinical decision support tool in terms of when to titrate medications, when to add medications, and it kind of spelled it out in almost a protocolized format. And what they wanted to look at was, here's where we started, like how much did we improve, hence improve HF, how much did we improve when we protocolized this or implemented a practice like this. As you can see here, in those patients, so we had a higher percentage at baseline that were on those therapies. I don't know if that's skewed because of the population that they were looking at. I don't know exactly the size of the clinics and how much help they had and things of that nature, but they started out with a much higher baseline therapy, and then they also saw significant improvements in all three groups, as you can see there on the right side. I added in the CHAMP heart failure registry just to compare and show that for whatever reason, I don't know if if it's selection bias based on it being all comers and some of that information, but basically the numbers are a lot lower on the right side than they are in the IMPROVE HF trial. So we didn't take the things that we learned from IMPROVE, and we haven't been able to implement them all that well. So how can we maybe work on doing this in the future? Some may say, okay, well, you're breaking down the ACE-ARBs here and you're adding ARNIs because those were not around back in the IMPROVE era. However, if you look at those in combination, only 16.8% of those were on a therapy at baseline. So it doesn't really change the numbers all that often there. So does dose really matter? We know that we've heard all of this information. This was the guidelines say. Well, why did the guidelines say it, and why is it? Why do we do this? So there's been 3 different trials that have looked at kind of your primary, your primary agents for heart failure. So ARBs, beta blockers, and ACE inhibitors. There is some anecdotal data also with the ARNIs. I did not include it here in this study. I believe it was all a sub-study from the Paradigm HF group. These were all studies that were done separately to assess high versus low dose therapy in heart failure patients. So as you can see, all of them have shown a reduction in death and hospitalization that was seen in incremental amounts with increasing these doses. And so this is really why, and then the MOCA trial as well was actually able to show an improvement in ejection fraction at 6 months as well by getting to higher doses of carvedilol therapy. So these are really the background and the meat and the bones of why we're really targeting these higher dose therapies and what we're trying to do for those patients. So why aren't we getting to goal? So as I said before, going back to the CHAMP heart failure registry, the goal of that trial was to say, number 1, are we getting to goal, or are we getting all these medications on board? And then number 2, if we're not, why aren't we? And what can we do, and what things do we need to target and hone in on, and how are we going to help fix some of these problems? So as you can see here, these were all against just, they took the data and they kind of did some associations between what was associated with lower dosing and not reaching those doses or not being on therapy. Some of the common themes that stand out to me are probably things that you would expect and see in your clinic or in your practice very often would be older age. So those patients who are elderly and more frail and more concerned about tolerability from a blood pressure standpoint, or may have some baseline renal dysfunction. Renal insufficiency, again, was seen both in the ACE-ARB-ARNI group as well as the aldosterone antagonist group, which I think is something we would all expect as well. Some past medical history, asthma, COPD over there in the beta blocker group, which I know is sometimes commonly a holdup for those patients. And then those who seem to have more of a worse functional class or are having more heart failure hospitalizations are also on the at-risk population. All right, so managing blood pressure. So how low is too low? We all know that these patients, when they have a reduced ejection fraction, their contractility is somewhat compromised and therefore don't always mount the best blood pressure to begin with. And now you're telling me, or I'm telling you, that you need to add in all these medications that can affect blood pressure, and they're 70 years old. How do I navigate this, and what do I do? Well, how low is too low? Let's see if we can find out some information. This is, again, a secondary analysis from the CHAMP registry looking at specifically patients and what their blood pressure did and how that influenced prescribing practices. So as you can see here, there were still pretty decent numbers of patients who were receiving therapy. Again, we're still in the 30 or below percentage overall for these patients, but patients were still on therapy. There were less patients that were transitioned over to the ARNI therapy. And again, I think as a whole, we saw that throughout the entire trial. But I thought it was interesting, these are patients with systolic blood pressure higher than or equal to 110 millimeters of mercury. Then if you look over here at those with less than 110, they actually saw very similar numbers of initiated therapy. So this is what I consider this group to be, patients who are on some type of therapy at a not goal dose. But there were much fewer patients over here on the right side of the screen who were achieving those therapeutic, or not therapeutic, excuse me, but target goal doses for each of these therapeutic classes. In addition here, so COMET was a trial done years ago that compared carvedilol to metoprolol tartrate. They also did a post hoc analysis evaluating blood pressure and how blood pressure affected dosing strategies, as well as how it affected some of their mortality and morbidity as well. And so you can see here, this is patients who were on a beta blocker at target doses versus those who were on just any dose. You can see there's much higher mortality in the percentage or the group of patients who were below their target doses. And then down here, the mortality is probably closer to 30, 25%, depending on which one you're looking at. Ideally, the carvedilol line would be what we're kind of targeting there. So 25% in 5 years versus up here, it's probably 35 to 40%. So again, some more information that's kind of telling us we do want to get to the goal dose, but then where does the blood pressure fall in here? This also looked at their blood pressure at 4 months and looking at those who had a systolic of less than or equal to 120 or greater than 120, which if I had a patient come into clinic with a systolic of 120, I would be like, awesome, we can do a lot of work here, this is great. So this cutoff might be a little bit high and maybe something that might not mean as much as the previous slide did in comparison with a lower blood pressure. But as you can see here, so the mortality was similar amongst both of those groups with the differences in blood pressure. Oh, I think we froze. So back to the main question that I asked before, or was kind of introducing. So how low really is too low? And that, I think, is something everyone struggles with. Clinically significant hypotension is something that in the literature and a lot of people will utilize maybe a systolic of less than 90 as their hard and fast cutoff. And I'd say we're probably pretty close to that. 90 is sometimes where some of our patients will live, 92, 94. We still will keep them on therapies. And what we do is we really just do a very good job of having them understand the need for blood pressure logs, heart rate logs, and for symptom evaluation. So we harp a lot on the number, doesn't matter as much to us. It's really all about the symptoms. Are they feeling lightheaded? Are they feeling dizzy? Are we worried about them having syncopal episodes? Hopefully that's not the case, but some of these prodrome type symptoms, are they having those? If they start to have symptoms at a blood pressure of 90, or if they're having symptoms at a blood pressure of 100, would probably caution us to potentially not increase their doses or keep them where they're at and evaluate them in another 2 weeks. As I said, Rome wasn't built in a day, so titrations don't have to be over a 2-week time period. If you titrate every 2 weeks, ideally getting to goal doses of all of these therapies within 2 to 4 months, that is perfectly fine. Again, just making sure we're reevaluating our patients when they come into the clinic. And again, if they do have some of the symptoms as above, taking a longer period of time to titrate is completely reasonable if we're questioning if they'll tolerate it or not. Someone who's previously, so someone you have in clinic who's normally on valsartan, they're on metoprolol, and they're on spironolactone, and they come in, you haven't seen them in a couple of months, but then they come in and they're now all of a sudden hypotensive, where they've been tolerating these therapies for weeks, years, however long you've had them on that. I'd evaluate their fluid status first, consider evaluating that. Maybe they're getting over-diuresed, especially if you're in the time period of also adjusting diuretic therapy. That's a lot of times where we will see patients develop hypotension as they're getting their diuretic adjusted, and then they're also adjusting some of their afterload reduction, and then doing too many things and having too many cooks in the kitchen at one time. kind of tends to take a couple of steps back for us. So again, evaluating their fluid status if they're abruptly changing, and have there been any other changes in their intake or their output from a diuretic standpoint. So some other things to consider. Again, I am a proponent of, I like metoprolol succinate, Toprol, or I can't say Toprol, sorry, but I like metoprolol succinate over, not over carvedilol, but the compliance standpoint of once a day is nice for, I think, these patients a lot of the time. And it's also a pure beta agonist versus, or antagonist, sorry, I don't know what that, sorry about that, versus having the alpha activity of the carvedilol. So there is, some literature that there'll be a difference in blood pressure when using metoprolol succinate versus carvedilol. The carvedilol will reduce by about, 5 to 10 millimeters of mercury more than the metoprolol succinate will, and therefore could be something to consider in someone who may be borderline on their blood pressure to help be able to titrate some of their afterload reduction or their ACE inhibitor or their ARB. From that standpoint. For highly compliant patients, I know we all probably have a lot of these, but if you can consider that spacing out their medications, so sometimes, especially elderly patients, don't tolerate taking all 3 of these medications first thing in the morning, and so if you can space them out by 2 hours, have them take their lisinopril first thing in the morning, have them take their beta blocker 2 or 3 hours later, or even take their beta blocker at night, or take their blood pressure medication, their lisinopril at night. Those can be options and kind of strategies to help mitigate the hypotension and the effects that these patients may see. If you're really struggling to be able to titrate any of the guideline-directed therapies, it's potentially a time to consider referral for advanced therapies to see if they would be a candidate, because, it takes a while for that whole workup and that whole process to go through. So again, getting them keyed in early is better than waiting too late. So the other issue that can arise, combating hyperkalemia. I know this actually just recently came up in our clinic and was something that we were triaging with one of our patients. But not all potassium binders are created equal, and I caution you guys all with this because this Lokelma is a new medication, or sodium zirconium cyclosalate. That's a newer medication, new formulation that just came out. All of them are some form of potassium binder to help excrete potassium to, hopefully optimize guideline-directed therapy in patients with CKD who end up with high potassium levels. And the second formulation here, it has 400 milligrams of sodium per 5-gram dose. The recommended dosing strategy for this therapy and for initial therapy is 15 grams 3 times a day, which, just doing some quick math, means that your patient's getting 2.4 grams of sodium per day just based on this medication. And I know we all probably discuss multiple times with our patients, I know we do in clinic, how important it is to avoid sodium, low sodium diets, and avoiding extra sodium content that they don't need is imperative for them. So we actually, have fought pretty hard against the use of this. Some of the insurance companies prefer it. I don't know if it's a cost perspective, but we've tried to fight, and advocate that our patients, this is probably not the best option for them, and will make our titration of diuretics to be a lot more difficult in that setting. So again, the patiromer formulation does not have any sodium in it, and then the K-Xlate formulation does not have any sodium that really is retained at that point. It makes me a little bit nervous because it's an as-needed medication from that standpoint, but either of the first or the third, are options for use in some of these patients as an outpatient for those with hyperkalemia. So I just want to touch on the safe initiation and utilization of the ARNI therapies. So in 2016, after the Paradigm Heart Failure trial came out, is really when the sacubitril valsartan is the only ARNI that's on the market as of now, but when it really made its way into the guidelines for use, and now it's actually recommended as an equivalent of an ACE inhibitor or an ARB, and then also recommended that those who are on stable doses or of those chronic therapies can be transitioned over for further reduction in morbidity and mortality. This is just kind of a reminder slide. Always important to remember when initiating that therapy, it requires a 36-hour washout from the previous dose of an ACE inhibitor. So if someone comes into clinic and had taken their medications that morning. If they come in on a Wednesday, they took their lisinopril. If you're planning to transition them to Entresto, you would have to wait until Friday morning. Sorry, I shouldn't say Entresto. Still not sold on them, so we are big proponents here in our clinic. We utilize sacubitril/valsartan very frequently in our patients. It helps not only with the morbidity and mortality data, but there's some improvement in diuresis from these patients. We've seen improvements in ejection fraction anecdotally. So we utilize them a lot. It is a medication that we try really hard to also get access to for our patients, which I'll go into in just a bit. These are pretty much the 3 trials that kind of talk about the use of sacubitril/valsartan. And the Paradigm HF was a really big ambulatory study that brought it kind of to market, compared it to the enalapril, saw the reduction in cardiovascular death and hospitalizations. Again, the issue that a lot of providers, and we do run into, is it does have a more profound effect on blood pressure. So from a tolerability standpoint, it's something to monitor a little bit more frequently than maybe some of the other agents that we've been utilizing in the past. Transition was a trial that looked at when to initiate this therapy. Is it safe to initiate it when someone's in the hospital, or does it strictly need to be an ambulatory medication? And they found that it was safe to utilize in both populations of patients, and this has really increased, our utilization as an inpatient and transition to the outpatient setting. They had a large group of patients who were able to achieve those target doses as well, which is a good sign. And then Pioneer was just recently published in, I believe it was November, that looked at patients who came in acutely decompensated, probably less of a discussion to have here since we're primarily focusing on ambulatory care. However, it did kind of show that it's safe to initiate in that patient once they've met certain parameters. They're no longer on inotropic therapy. They're no longer on IV vasodilators, on IV diuretics. They've kind of, once you're transitioning them to get towards discharge, it appears to be a safe agent to initiate then. Did still see high rates of hypotension, but again, it wasn't statistically significantly different than the enalapril group. So how to make a safe transition. This is generally the, algorithm or kind of guideline that we'll utilize from a dosing standpoint in terms of what's considered a low dose, a moderate dose, and high dose. As you can see here in the outpatient setting, we will not ever, and even in the inpatient setting, we really never transition someone directly to the highest dose of Entresto. We are always going to start at the moderate dose, and this is probably a little bit more conservative. If I were to tell you what we would do in the inpatient setting, it may be a little bit more aggressive from that standpoint. But this is just kind of for your reference to utilize as you go forward. If you adopt using this therapy and you're not sure, you're on the border of which of these to utilize. Again, it's a conservative strategy, and again, if you're always concerned, you can always bump up one dosing strategy if you're concerned about a patient. The last thing, great drug, but you can't get it covered. This is something that we also, I failed to mention at the beginning, our clinic does have a designated case manager who helps us out a lot with a lot of these prior authorizations and how to really get this drug covered. But as you can see here, there are free 30-day trial cards that can be accessed, I believe, online. I'm not 100% positive of that, but they can be given for a period of time. And then if patients fall into any of these buckets, you can consider reaching out to some of these organizations and or utilizing a copay card if they fit into the commercial insurance bucket. So it does take some manpower. As I said, it's going to take a village, but we have been able to successfully really get this medication to a majority of our patients and be able to get them continued access to it. It just takes some time from that standpoint, but is usually something that's doable. It also requires, again, if you're going to do any of the patient assistance programs, it requires some initiative on the patient's part. They usually have to fill out part of the paperwork as well, but it can be done. This is just some stuff about preparing for prior authorizations. I know a lot of the West Virginia, I believe Medicaid, I don't know about Medicare, but I do know we've gotten a lot of, some of them actually don't require prior authorizations for some of these medications anymore, but it's just something to keep in mind, I guess, as you're preparing to talk to them. I'm sure you guys have all done these on your own, so I won't go through anything. It's nothing earth-shattering, but just stuff to have ready for your discussion if you're going to just talk to these companies. And then just a reminder again, so the I need help acronym is always something to remember, and I think here the P, or progressive intolerance or down titration of guideline-directed therapies. If you're seeing this in clinic, that may be a patient to consider for a referral for if they would be an advanced therapies candidate. Last but not least, I don't have anything profound to say regarding the ARB recall. Unfortunately, actually, the FDA just came out with a statement overnight last night that I think it was published in CNN, so a lot of your patients will now be seeing it, encouraging them not to abruptly stop their medications, because that's been the issue that we've run into, is these patients get a notification from their insurance provider or from the pharmaceutical company or whomever it is, that they now have this product that has been tainted, and they just decide or try to stop taking the therapy. So they've encouraged patients not to do that. The risk of stroke and other adverse events from withdrawing is greater than the small risk of the cancer development over the couple of days while we're getting all this stuff transitioned. But here is a dosing chart. This is adapted from the Atrium Cardiology Collaborative in the corner over there, that has come up with a good dosing strategy to go in between your ARB dosing if you needed to transition your patients over. Again, going back to the second or third slide, that would also, you'd be able to expand that out to your ACE inhibitors. There's not one that we've made yet that directly shows kind of comparisons for that group. But that's all I got for you guys. What questions and discussion and what kinds of things can we help out with here? Oh, thank you.
All right, guys.
Yes, can you hear me?
Yes.
I'm sorry, this is Bob Gorowski,
Hi there.
and I treat a lot of outpatient heart failure patients in primary care. You prefaced your talk by saying HFrEF is an EF less than 40%. Does that mean all the studies that you just now presented in guidelines refer only to people with EFs less than 40%?
So there are some trials years ago that actually had a more strict guide or ejection fraction cutoff of less than or equal to 35%. In the last year, in the last couple of decades or so, or probably at least 5 years, that has been expanded to include those with an ejection fraction less than 40%. So a majority of the patients are going to be less than or equal to 40%, yes.
Now the people that you see in your advanced heart failure world are all going to be less than 40. Out in the community, we see a lot of people between 40 and 50. What are we supposed to do with those people?
So generally speaking, I think those, mid-range ejection fraction is now what the European Society is calling them. I think a lot of times they'll probably fit into the bucket of qualifying for these therapies. They may have history of diabetes, CKD, they may have other comorbidities that would then kind of lump them into the benefit group of being on some of these guideline-directed therapies. And I honestly, from the most part, we pretty much treat them the same way. If you're looking at, I think the only medication that would really probably, they would not technically qualify for and you would have issues getting approved or really utilizing would be that sacubitril valsartan, because a lot of the insurance companies will want the document with that reduced ejection fraction. So you would potentially not be able, would not maybe be a candidate for those therapies, but I do think they'd be a candidate for pretty much any of the other therapies that we discussed. So the ACEs, the ARBs, the beta blockers, and then the mineralocorticoid receptor antagonists.
Okay, thank you.
And it's not the exact question, but it was something that I meant to discuss at some point and I forgot. But for those patients who have a reduced ejection fraction and then they improve on guideline-directed therapy, what do we do with those patients, and really how do we manage them? So if they have had a reduced ejection fraction, they've been on guideline therapies, we've seen that improvement in their ejection fraction, There was a recent study that came out at the end of November called the TREAD-HF trial that was a small subset of patients, but they started to withdraw therapy. And they said, well, now that the ejection fraction has improved, let's slowly take away some of these therapies. And within 4 weeks' time of reducing those guideline-directed therapies, they actually saw a worsening of the ejection fraction by echocardiography. And I do believe that correlated with symptoms. I'm not sure. I'd have to go back and double check exactly if they were receiving or if they were showing an increase in symptoms as well. So from a standpoint of if they were reduced at one point, we treat them as reduced for the progression of the disease.
Great, thank you, Rachel. Dr. Pollywall, did you have a question?
Yes. Can you talk about when to use that Corlin, or I know I'm using that Ivabradine.
Yeah.
When do you use that? And can we use that with beta blocker?
Mm-hmm. Yeah, so the Ivabradine, which was or Corlinar, which is really actually how it's marketed now, it's only a brand product, was studied in the HFrEF trial, and what they actually used it in is patients who are on optimal dose of a beta blocker, which is pretty much as they would tolerate if they became hypotensive or hemodynamically unstable with increased doses of beta blocker. It would be whatever they could tolerate. It didn't have to be a maximum dose. But whatever they tolerated, they had to be within normal sinus rhythm. Because that drug did actually show an increased incidence of atrial fibrillation in that initial study. I think it was 3 to 5% of patients developed atrial fibrillation. That correlation, I can't exactly tell you if it's drug-related or not. I mean, it's a signal there that it may be drug-related, but they recommend patients be in normal sinus rhythm and then still have a heart rate greater than or equal to 80. And so from that standpoint, the thought there is that you're decreasing that sympathetic or the heart work, I guess, from the standpoint of decreasing contractility and the amount of contractility throughout patients with still elevated heart rates. So we use it occasionally here and there, but not a ton. Did you have a specific question about like a specific patient or?
No, I was just asking. I mean, I know that I was under the impression we can use it when heart rate is more than 70.
Mm-hmm.
Okay. But yeah. In outpatient setting, I have never used it. I've seen some cardiology using it. I was just uncomfortable when to use it.
Yeah. I mean, I think I can, off the top of my head, I can think of like 3 patients that we've started it on since I've been here since August. So we really don't use it in a ton of patients. From that standpoint, but it would be somebody who's got a persistently elevated heart rate, and you're really probably only going to see a reduction in hospitality. Sorry, hospitalizations. But mm-hmm.
Guys, we have about 3 minutes left. Did you guys have any more questions? Excellent. Thank you so much, Rachel. We really appreciate it.
Sorry, it talked longer than I expected, but we didn't have anything else going on, so hopefully it's something helpful. And if any of these slides are can be used for reference or anything like that, please feel free to utilize them.
I want to ask Dr. Goralski here, is that a patient with a history of non-ischemic cardiomyopathy, like in the past, if they had like ejection fraction close to 30, 40, and they now improved, like their ejection fraction is now persistently like 50. Okay, now I would continue beta blocker and ACE inhibitor, but do we need to continue the diuretic, the Lasix and the spironolactone?
Well, can you hear me?
Yes, yes.
If you're asking my opinion, I am hesitant to stop beta blockers, ACE ARBs. The diuretics, I'll get people also quickly if they're improving and do not have fluid overload. I'm not afraid to get off of the Lasix and so forth. But the issue that she brought up earlier about the study, I had not seen that study. Looking at the question of people who get better, should you systematically start down titrating? And the answer was no. That's important information, and maybe we can extrapolate that to, maybe just reducing drug doses if they're having the least bit of side effects. I've had people, and we're talking about not the severe heart failure patients, who do well with aggressive therapy, but they're living at a blood pressure of 100, and they're not, they're still somewhat more feeble than maybe you think they ought to be. Their EF maybe came up some, maybe they just feel better. And if you back titrate just to give them an extra 10 points of blood pressure, I've seen a lot of people just feel so much better. I worry I may be losing some of my beneficial effects on their longevity, but I tell them that, and they tell me they'd rather feel better. And these are not people who are in the hospital all the time. These are outpatients who are doing fairly well. That I do down titrate in some cases if they're hypotensive and feeling sluggish.
Yeah, and the trial itself didn't specifically talk about, they were completely, the attempt was to take them off completely and to completely withdraw medication. So a dose reduction, if they're feeling crappy, could be potentially reasonable, I think, from that standpoint. But trying to keep something on board, again, to keep that renin-angiotensin system at bay and decrease that sympathetic surge from a beta blocker standpoint, I think seems to be appropriate and something that would benefit long term.
Thank you.
Thank you.
All right, guys. So we're at the end of our session. I thank you all for participating in everything today. I did want to let you know our online form is live. So if you guys have any case questions or anything like that, you do not have to fill out the entire form. If you just have a simple question or anything like that, just go ahead and throw that in the additional notes or questions. But I'll be sending that out with a session recap from today. And then let us know if there are any topics in this realm that you would like to hear about also. And then the last thing is that our next session is scheduled for April 19th, but because that is a holiday, that is canceled, obviously. I know a lot of the clinics won't be open, but I know WVU certainly won't be open. So let me know if you have any questions in that kind of longish break. I think we will reconvene on May 3rd. I think that's the next one. So everybody have a wonderful day, and hopefully the weather warms up so we can all enjoy it. Everybody have a great day.
Thank you. Thank you, guys.